Good morning, Matias, from San Diego. Thank you very much for being with us. This is, as you know, this is a program that we call Global Leadership Summit. We have physicians from different countries of the world. Every time that we do this program, we have from different places. We have physicians from Korea, from Mexico, from Brazil, and from Azerbaijan. So everything is really international from the point of view. But the nice thing, Matthias, is that no matter what you see, there is a consistency in the way that people do cases and treat the patients. And this is something very nice. Also, we have two US physicians as a faculty, one interventional cardiologist. It's Amit Bora. Amit was basically the partner of Hemal. You know him in person
Yes,
from
absolutely.
Harrisburg. Now he's working in Yale. He's going to the high leagues in Yale. And then we have also Dr. Jacob de la Rosa, who is from Hispanic family, and he's a cardiac surgeon. He's not guilty. It's something that he chose when he was in the School of Medicine. You know, surgeons. I mean, I understand they are not our super friends, but he's really friendly. So Matthias, and then we have a nice group of experts from different parts of the world. So I don't know, Amit, if you want to say some words, or we can start. Or Jacob.
Yeah, no, I think that, thank you so much for helping us and walking us through your case. I think that we're eager to sort of get started.
Okay. Thank you, Juan, Amit, Jacob, everything that are there in San Diego. Here in Buenos Aires, it's a little bit cloudy, so it's not too bad to be in the cat lab in a weekend. But first of all, I would like to thank all this team of all this group that is working on Saturday, and also the patient that is coming with us on Saturday. But I want to say something important that for me is the one highlight in this center is that the majority of people that are in this room are women. So I was counting how many women are in the room, and there are six women versus 3 men. So this is a real meal women's interventional cardiologist cath lab. So in my left side is Veronica.
Hi, good morning.
Veronica will be the first operator in this case. And here is Maxi. Maxi is finishing his fellow with us. And also we have a team of technicians and a nurse and the anesthesiologist that is Marcelo. She is Soledad, and Mariela is also with us. And here the technician of Medtronic also help us. So I want to say that, but no more speech, and let's go directly to the case. We will show you what we prepared for today, and after that, let me know if there are any questions, okay?
Good morning from the Sanatorio of Inoquieto. I am Maximiliano Jara, and I'm going to present the clinical case, and then I mention a little about the planning of the case. Our patient is a 87-year-old male with a body mass index of 28, and his medical history includes hypertension, former smoker, chronic kidney disease, and history of sinus node disease with pacemaker implant in 2017, have a severe aortic valve stenosis symptomatic with dyspnea and angina, and his current treatment includes furosemida, valsartan, lercanidipine, and nebivolol. The echo shows a ejection fraction preserved with 62% and a severe aortic valve stenosis with a mean gradient of 41 millimeters mercury and an aortic valve area of 0.8 centimeters square. And the estimated pulmonary pressure was 49 millimeters mercury. The analytics was normal except for the usual creatinine of 2, and his EKG has a pacemaker rhythm. The left coronary angiography didn't show significant lesions. but we found in the right coronary artery stenosis, a significant stenosis in the ostium of the right coronary artery. And in the patient with angina, we perform a angioplasty. The Euro score is 8, and the STS score predict risk of mortality was 12%. One of the most important points of the planning is the CT analysis, and here we have the annulus measurement with perimeters of 84.7 millimeters with an area of 549 millimeters square. And both coronary height are okay, 18 and 24. The mean of diameter of the sinus of Valsalva is 36 millimeters, and the diameters of LVOT are 21 and 33 millimeters. And the valve plan has a 46-degree angulation. And because of the lack of the access image at the CT, we perform this angiography, in which one we observe some vascular tortuosity in both axes without any significant stenosis. So the strategy is conscious sedation, echo-guided right and left femoral access. We chose the left for the valve advance because we have an echo with a pseudoaneurysm in the right femoral artery. Wire pacing and predilatation with non-compliance balloon number 22. We show a Medtronic Evolut Pro Plus number 34. We use cast overlap technique with right 36 and caudal 30, and per close femoral artery with ProGlide. Thank you.
Excellent. Thank you so much, Maximilian.
Okay, so did you see all the case? And if there are any questions, I would like to add something. The pseudoaneurysm in the right femoral artery was because of the last procedure that we did, the PCI, but it's closed, it's spontaneously closed, so it's not an issue, but we don't want to make a puncture again in this site, so we change the strategy and we place a pigtail biradial, right radial approach. That is the unique change. So if there are any questions, please, we are open to this.
So Matthias, one question that I wanted to ask you. So I noticed that the patient's creatinine is pretty elevated, right? It's 2.3, which kind of puts us in sort of CKD state, essentially stage 4. What, if any, procedural modifications do you do in these patients that have bad kidneys to try to minimize the risk of acute kidney injury?
Okay, that is a very important point, and obviously this is the main topic in this patient. So first, we try to, the CT was referred for another hospital, and in this CT didn't have the access, so we did not repeat the CT when we did the catheterism, the coronary catheterism. We did a very, very small contrast injection in both arteries. So we use in total 75 millimeters of contrast to make the coronariography, the PCI to the ostium of the right coronary artery, and also the assessment of the vascular access. Another thing that we plan in this case is to use the less contrast as possible. So let me say something. The echographist is in the room, and we are going to make all the procedure guided by angio with less contrast as possible, but also we are going to check the final result only by echo. We decide to do not do the procedure under transesophageal echo because the age of the patient, because the risk of the patient. So we have a good cardiac window to perform final result assessment by echo. And also another thing that we did was perform the peripheral access using echo-guided. So can you see the angio? So you are
Yeah, we
seeing
can see
now.
it.
So first, we did a very meticulous ultrasound guided puncture. And then, as you can see, we advanced the wire that there are some tortuosity and also some calcification that is a concern to put a 34 Pro Plus. And then we try to place the proglides. We use true proglides because we don't need vascular complication in this case. We don't want to use contrast to fix arteries and something like that. So the main caution that we use was that. If there are any other opinion and you suggest something, let me know. But these are the points of the case.
No, I think that sounds great. And I think just to highlight to the team here that the linchpin of a case like this is excellent CT planning. That if you have a good high quality CT and that you spend time with it, you can actually do the entire case with extremely low amounts of contrast with the exact modifications that you suggested. You know, instead of taking angiography of the legs, just do good ultrasound guided vascular access. You already know exactly where the calcium is, what the calcifications are from the CT scan. And then also when you're deploying the valve, because you know sort of where everything is based on your assessment of the CT scan, really you can do the entire case, I think, you know, if you absolutely needed to, with less than 5 to 10 cc of contrast and still get the images, the views that you want, all without significant difficulty.
Okay, yeah, I'm agree. So that we did is, as you say, a meticulous analysis of the CT, and we did, poneme esta pantalla. We did an angio in cast overlap, la repetición. You can see the repetition. You have to see. Okay, so we don't have this image, but let me check if we can see you. Put angio. We are going
perfect.
to try to fix. Now you are seeing the angio.
Yes. Yes.
Okay, so that we did is based on the CT analysis, make only 10 cc of contrast to check if the cast overlap view is okay. In my opinion, and also Veronica opinion and Maxi, this is a good projection. Something that I want to highlight is this: all this analysis of CT is made by Maxi. Maxi is the fellow, and our fellow are totally involved in the analysis of the CT. So we are very confident with this analysis. So we check, but he made it. So if you are agree, that is the position that we will use, and then we are going to try to put the valve with only 5 cc's and 5 and 5 and 5, no more than 100, and let's see the result by echo CT, by echo guidance. So the situation now, if you can put the camera here, the setting is we have an 80 French sheet in the left groin. And that's because we want to check if because this tortuosity, the Evolut Pro Plus would advance perfect, and it seems that it's okay. But if it's not, we are going to switch the Evolut Pro Plus by a 20 French size sheet, and we are going to advance an Evolutor. But I'm very confident that it will go through. And then we have the radial access, and we have the coccygeal in the right groin to do wire pacing. So let's advance. Another important thing is that we are going to use a Landerquist wire. So can you put pones las hemodinamias? Can you put the hemodynamics in?
Sesiones.
If there are any questions, let me know. Who or you are going, in this case, would use another wire that is not a Landerquist?
No, con la bomba. La bomba.
Matthias was the first physician in Latin America doing the
Hector.
CUSP overlap case. And when we were with you and Gemma there,
Yeah.
I called him by phone and I explained him how to do the CUSP overlap position.
Yeah.
He has a 34 valve in the lab in that moment. And so he recalculated everything and he did the first case. So basically, he's following the rule and he's really trying to use Landerquist or even Mayer wires when he doesn't have Landerquist. So you will not see him doing like safaris of wires and push-power.
I think that, Matez, this is the perfect case to use double curve Lunderquist, I think, for a number of reasons. Number one is that you have significant tortuosity in the iliofemoral anatomy, and so the Lunderquist will strain that out
Marce,
better than
saturación,
any
Marce.
other wire. The second is that, I think with Evolut R34, it's a 16 French system. But it will give you some additional stability and additional support as you use it to deliver the valve. This is a case where I think we don't have to be as precise. I mean, I think you can be very, very precise, but the priority here, given that the patient already has a pacemaker, is to make sure that you have good enough depth, that you have seal, that if you need to post-dilate the valve, you absolutely can, but not so, you don't have to be so exact because the patient already has a permanent pacemaker.
Absolutely, absolutely. So we're going to try to be not as you say, be extremely gas overlap, zero implantation, because as you say, we need a good result, and we are not worried about the pacemaker. But anyway, if we put the valve too low, we have some aortic regurgitation because the skirt is not catching the annulus. But let's see. So another important thing that maybe you can talk in the room is if go with pre-dilatation or not. We have decided to go. Tenemos que sacar el.
Sí, sí, el 7.
We decide to go with pre-dilatation because we think that there are calcification and all, and maybe it's better to make the procedure smooth and try to use less quantity of contrast. But how many of you would do this procedure directly without pre-dilatation?
So maybe we'll just do a show of hands in the room. How many of you raise your hand if you would pre-dilate this valve? 34? For 34, exactly. So I think that we have, I don't know, a third maybe?
The rest of you would not. Let's go for it.
Espérame. So there are
Guys,
some.
I think, again, for what it's worth, I think it's very reasonable to pre-dilate this. Again, like the priority is just making sure that the actual valve deployment is as smooth as possible. I think the last thing that you want is a scenario where the valve is constrained for any reason and you have to take it out, recross the arch, the whole thing. And so if you can just do one quick pre-dilation to facilitate appropriate expansion of the valve, I think it's reasonable.
Okay.
Doctor, ¿estamos para marcapasos?
Probamos marcapaso, Marce. We are going to
And it
do
looks
wire
like
pacing.
true
And
blue.
Listo.
okay,
Cortamos.
cortamos. As you can see, we have a good capture of the pacemaker, wire pacemaking. So we are
Vamos.
going to advance with this. Manejalo.
Ajá. Marcapasos.
No tan-
Ahí.
Prendemos marcapaso, Marce.
Vamos. Ya está.
So there are good capture. We are go in
Ajá.
and out. This is a
Cortamos
22
marcapaso.
millimeters balloon.
Cortamos.
Mataz, you're pacing over the wire?
Yeah, absolutely.
Excellent.
Guarda con la cuerda.
You guys notice that? Over the wire.
Okay.
Can you do me a favor and then just show us or explain that a little bit and then just show us where the clips are
Absolutely, yes.
for the
So
rest of the team here?
there are some important points when we do wire pacing. The first is to be isolated. So we need a catheter as a balloon to isolate all the aorta and only have the voltage and the electricity in the ventricle. So this is the first step. Second step is you have to have a clip, the crocodile. I don't know if you can put my hands here. Keep a crocodile in the wire. There are wires that are more conductance than others. The Landerquist is very nice to conduct. And the other point is to have in the groin one needle that is touching the skin, it's through the skin. And the other important point is to have maximum output in the pacemaker. So if you are not with max output, it do not going to go pacing. So if we don't have trouble, we are going to take it out, the balloon of the sheet. This is a non-compliant balloon, 22. Maybe I want to ask something to all of you. We did it with the 22 balloon. Someone of you would do that with a bigger balloon. Ahora vamos a antero-posterior.
Yeah, I think it's a good question. I think that there are obviously many different ways to do it. As you know, Hemel and I tend to be a little bit more aggressive with the balloon, primarily because of how costly the true balloon is, so that we rarely like to open more than one during the case. But honestly, I think that, in a case like this, you have a fair bit of calcium at the leaflet tips of the actual leaflets, but there isn't a tremendous bulk that if you can just make a little bit of space to facilitate valve deployment, I don't think you're going to need. I don't think you're going to need to post dilate this one. I think a 22 is completely reasonable.
Okay, thank you. Yeah, we was discussing that. So we are going to change now the sheet, the 18 French sheet, and try to advance. Try to advance the 34 Pro Plus. Obviously, we want to have here the FX that have 2 millimeters less, but this will be very, very soon. We have seen yesterday in Balvin Rio very nice cases with FX, but I think that with this technology we also can do this case. So let's see. We are going to put bien panorámico para ver la ingle. So in this case, it's important to see the wire in the ventricle and also the access in the groin. Okay, más abajo. We can see everything. Para bajar el flat. So we are very confident to pass through. Okay, very nice. Look, in this case, the Landerquist have helped a lot because we have some difficulties to advance the 80 French sheet using a common Amplatz wire. So we are in. Let me explain something. Here, the device is in our tree, so we have our port in our tree. We are going to try to make commissural alignment. Obviously, the patient is 87 years old, so we are not very worried about the coronary access, but as you remember, it has a recent PCI to the right coronary, so we would not to avoid this access. So we are going to go in our tree, and we are going to advance.
Arriba.
As you can see,
and so again, I just want to point out to the team here about the hat marker on the right side of the screen to ensure commissural alignment. Sorry, yeah. I know you were just going to say that.
Yeah, you can see here. No, it's the radiopacal marker is in the outer curvature. Go ahead. Okay, so we are going now to the implant position, and we are going to ask to the anesthesiology to set the pacemaker in 140 to make the final part of implantation, but not now. O sea, Marce, ponete a 140, pero no ahora.
The other thing that I just want to point out to the audience here is look to see how that catheter behaved with respect to hugging the outer curve with the Lunderquist wire compared with the Safari. So, Matthias, we've had 4 live cases, and of the 4 live cases, 2 have been Lunderquist and 2 have been Safari. And you can see, you can really appreciate the difference in the catheter position, or at least the space between where the pigtail is and where the delivery system is, based on which guide wire is being used.
Fíjate que el pigtail esté bien. Okay, there are some movements in the pigtail, so it's very important to have the pigtail inside. We are going to start here.
Creo que sí. Le hacemos.
No, espera. We are a little bit higher. Bájate un poquito. Mac, please. Pone un campo más.
Dame un segundo.
We are going
The
to
other thing
do.
that I'll
Sorry,
go ahead.
only cine to see the relation between the pigtail and the valve. No injectes. Okay. We try to spare the all contrast that possible. Yeah, we are hearing you. We are going to wait. The patient is stable, so we are going to wait to start with the angio again.
And the only other point that I'll make to the audience here is that, and again, like now you've seen a couple of cases of FX and a couple of cases using the Pro Plus platform. The starting position is slightly different for each of the platforms because the FX delivery system has that stability layer. You don't see the valve descend quite as much as with Pro Plus. And so with Pro Plus, you generally start a little bit higher, expecting the valve to descend, whereas with FX, you can start with that ring marker much closer to the base of the pigtail.
Okay,
No.
espera. Absolutely. So in this image, it looks that the position is okay. We are very quiet because at least the patient in this point is okay. Let's bajar un poquito. We don't want to be so high. Vale.
Contraste. Okay.
And what's your opinion? I think that we are okay there. We are going to
We
try
just,
to. Yeah,
yeah, no, that looks great.
yeah. Okay. Pacemaker, please. Marcapaso. Perfect. So
Perfecto.
we have some extra beats. Now it's more stable. I'm opening the test.
So operator 1 is leaning in just a little bit here.
Test.
Came out.
Okay.
Ok, vamos bajando marcapaso. 120. We're going to try to make only one cine without angio.
Vamos a.
Ahí.
Alineamos.
Hacemos cine. Okay.
Okay.
And now the question is if we are under, we have parallax or no. Maybe we have some parallax. So, metete un poquito
Caudal.
más caudal y más derecha. So we are going to try to avoid all parallax. Okay, we are okay here.
Vamos.
Dale, vamos a hacer un cine.
Inyectar.
Okay, we're at our 0. What's your opinion?
0.
Yeah, you're right at 0, huh?
There are a lot of experts, so I would like to know your opinion. I like it, honestly. We can share the guilty.
You know, I think that the main thing that caught my eye, at least, and Jacob and I were talking about, is that during the deployment, it looks like the valve kind of rode up a little bit, and so I think you started at 2 or 3, and then ended at 0. Now, I think that there are 2 ways that you can go about. You can either, swing LAO and make sure that you've caught on the left side, which I imagine that you have, but I certainly would check. And then lean in on it as you do the final deployment. And you can see that you are still kind of biased toward the inner curve here. So I do think that it's going to descend. I mean, the other alternative is to do a partial recapture and then just bring it in a millimeter or two.
Yeah,
Okay.
yeah. This is a very nice discussion. What I see is that that it's difficult to see with using Landerquist, but we are at 0 in the none, but we are deep in the left. We can check in the LAO, but I don't want to use too much contrast. Maybe you're right that we need to know if we catch the left, but in this case that there are renal dysfunction, I would decide to try to or leave the valve as it and try to make some
Partial.
pushing, not too much, but pushing on the left, because if we are going a little bit deeper with partial, this is another discussion, partial recapture or not. Maybe we are going to go a little bit deeper in the non. So Juan, what do you think?
Okay, Matias, I believe that you are a little high. My concern, and we were chatting that
Okay.
maybe you are not totally, we don't know exactly your position in LAO because I understand the contrast. And maybe if you are too deep, I don't know, I would suggest recapture and try to redeploy. That's my opinion.
Let me check.
And try to have a safer position in the non and maybe pushing the system to the external curvature with your wire so you can reduce the deep implant in the left side.
Absolutely, yeah. I will do another injection to see if there are any movement up or down to decide if you recapture or not.
Inyecta.
Okay. Let's mag.
If we see the fluoro because we see a perfect
Can we see the fluoro?
person because we see you like saying hello to you.
Yeah. We are
Because
going to show you the
close to the
fluoro.
camera.
Because this
And
fluoro
very
is
good
interesting. And also we can see the echo. Put fluoro
That's it,
and echo.
that's it. Okay. So you are, I'm sorry, but you are 1 or 0 in the non. It's tough. 0, no, but 1 at the most. And in the left side, you are not completely opposed. We are here with Roberto from Medtronic, Roberto Ramirez, who is part of the global training group. And he was also mentioning, that it's not fully released, but you still have some leak in the left. I mean, Jacob, what do you think?
The enemy of good is always better, and I think you're definitely deep on the left side. But you're going to, even if you recapture and bring it down to +1, or might end up at 2, you're still going to be deep on the left side unless you really put some push on the greater curvature.
Yeah.
So I think that's the exact point, right? And I'll just sort of highlight this to the audience, but again, look at where the valve is relative to where the delivery system is relative to the outer curve of the aorta, right? And so this is a scenario where, if the last movement is sort of pulling back on the catheter, it's going to straighten everything up, and that's going to lead to asymmetry between the non and the left. I think that you're right. Like one potential consequence of greater depth on the non is going to be even greater depth on the left. But I think that there is potentially a way, exactly as Jacob said, where with a recapture, if you lean in on it and try to push everything toward the outer curve, that you'll have a scenario where you may not have quite that much asymmetry.
Yeah.
But at the same time, looking at the echo there, and at least in some of those views, it looks like you do have sufficient depth on the echo.
Yeah, I'm agree with you. I think that the echo helps a lot to see if there are any part of the valve that is not inside of the annulus. What do you think? ¿Qué pensás? ¿Está toda la válvula metida o no?
Sí, Mati, está más o menos a 9 milímetros. veo leaks severos y me parece que está
Okay, the ecologists say that in the deepest part is at 9 millimeters. That I suppose that is in the left. So I try to. I will try. I honestly I know that if we push the wire, we can be more aligned, more coaxial. But I don't want to make too much aortic root shots in this patient because the renal function is very, very critical. So I would try to make the implantation under rapid pacing. Here, saca la mano así no te... hace un cine.
Dale.
Okay, it looks not bad. I will retrieve a little bit the wire. Marce, ponemos a 140.
¿Quieres hacer un cine más con contraste?
¿Eh?
Un cine más con contraste.
We are going to do 5 cc more, but in another projection. Anda
Izquierda.
un poquito más derecha, más caudal. Hace un cine. No, más caudal. No, we are not doing. We are trying to avoid all the parallax, but it's not possible. Andarte al anterior. It takes some time, I know, but it's important part of the procedure. There are not any penalty to recapture, but the penalty is to go too deep and high some. Hacemos un cine ahí.
10.45 era.
I have some leak. No, we have
10.45, eso.
parallax.
Menos derecha. Más caudal. Ok.
Inyectar.
Ok.
Okay. It seems to be a little bit high, so we are going to try to make a implantation again. So, okay, are you agree?
Yes.
Anda a esta proyección. 33, 33.
And so this is a good example of why it's important, even though the left looks super deep in the cusp overlap view, that second view is critical.
Ahí.
You know, we've tried to make it
Centrame.
as simple as possible, but not simpler. And I think that if you sort of cut corners in that one aspect, then that's, I think, when you can run into trouble.
Ok.
Ok, empuja un poquito. Ok, pacemaker, 140. We are going to deploy there.
Lo voy a grabar.
Dale. Marca paso. Empuja un poquito más. Ok. Listo, soltá. As you can see,
marcapaso.
cortemos marcapaso. The valve accommodate a little bit more. We are going to repeat. We did under rapid pacing. And there was not upward movements, only downward movements. That is was what we need. So for this task, we retrieve the wire a little bit, and Veronica some like a push in the catheter. So we are going to retrieve the nose cone and try to analyze by echo. A ver, buscamos una proyección. Ahora vamos a ver el eco, pero dame un minuto que buscamos una proyección.
Izquierda.
Ahí, okay. No, sin paralaje. 20 más acá.
Ahí estoy en 5,
Un poquito más caudal.
Más acá.
Sí, mejor.
Más arriba. Menos caudal. We are trying to avoid all parallax. No.
Un poco más.
Más craneal. Ahí. Más caudal. We are trying to avoid parallax. So
Ahí está.
let's check the echo, okay? ¿Me ponen eco en pantalla?
¿Me das la coleta que saco el catéter?
And also we are going to do hemodynamics. ¿Cómo ves el eco?
Mejor. En 5 o 6 milímetros.
¿Y cómo ves el leak? We are trying to figure it out if there are some leak, but as you can see, the depth of the implantation is not bad. In the non is 5 millimeters or maybe a little bit more. Deja cubrir las manos. Saca la flora. We are going to try to do not X-ray the echographist. That is also important. But let's see the leak.
No.
If there are no leak, we are finished the case here. We are going to also to watch hemodynamics. Pásame el introductor 18 French. Are you seeing the echo? Juan, any thoughts about the echo?
No, I mean, I think that it looks great. Congratulations. I think that this is it's an excellent result. It was an aggressive deployment, but I think leaning in on the catheter on that final deployment had the exact desired effect, which is bringing the valve down on the non-coronary and canting it a little bit more toward the outer curve. And so I don't think that you're going to need, based on these results, I don't think you're going to need to post-dilate it. The valve looks extremely well expanded, and so I don't think it's really constrained anywhere either.
Campo más panorámico. Thank you. Yeah, that was
¿Se capturó?
the most important part of the procedure, to try to saca un minuto la mano,
Sí.
así después vemos todo eco, to try to do not use too much contrast and try to make the all the procedure under echo. We have used a total of 54 millimeters of contrast that I think that is very nice for the ¿Tienes el 18 French preparado? It's very nice for the patient, so maybe it's not a very difficult case in terms of anatomic issues, but we would like to show you how to perform, or how we perform. Maybe there are another options, but how we perform patients with chronic kidney disease and try to minimize the kidney injury. So as you can see, the hemodynamics looks good. The PVE is not bad. We are going to place a pigtail inside, and if the echo shows no leak, we are going to leave the case as it, okay?
Decime cuando puedo mirar.
Any other comments? I have a question. Because it's also are you hearing me?
Yeah.
Hemodynamics,
Yes,
hemodynamics. So
We are listening.
So I have a question for all the audience, and also for Amit and Chakov, and also for Juan. There are a lot of people that would choose a balloon expandable valve in this case because it's easy to go. It's very easy to go. You implant the valve and that's it, no? But who of you are agree in implanting a self and who not? It's sorry, Juan, it's not a political question. But I would like to know all comments and why we choose this technology is because we are very familiarized with this technology, and we are familiarized with the implantation,
Vamos a dar
and
cero.
we know that the hemodynamics are perfect, no? And also it's not a patient with lot of longevity, because he's 87 years old, but that is what we choose.
Cero.
I would like to know your opinion.
Yeah, I mean, I think that, so for this particular case, I think, honestly, I think either probably would have been fine. But at the same time, I think that, you so expertly demonstrated that you don't really, I'm not sure that you could have necessarily made this that much easier. I mean, you got a great result with one deployment. You did not have to recapture. You knew exactly where you were. There was good stability in the deployment. I don't see how you would have a better result with a balloon expandable valve in this particular situation.
Foto. Yeah, thank you. Thank you. To remark that you are saying, please put the hemodynamics, because the hemodynamics are really perfect. We did not expect some good hemodynamics, and also put the echo, but based on these two results, echo and hemodynamics, as you say, I think that that showed that you don't have to choose the easier device to deploy. You have to choose the better device for the patient, no? And in this case, that the patient has pacemaker, the patient has severe calcified disease. So we think that it is one of the best devices to use. Okay. So if you are agree, we can close here with this result. We are dedicate some time to close the artery, but Veronica, you want to say something?
No, I think it's.
Can we put you in the screen, because we are seeing the echo, and we would like to see you
Ponemos
before
en la pantalla. No, pantalla nosotros.
Thank you, Matías.
I think this case is a very challenging in this point, because when you try to deploy a 34, sometimes, frequently, I would say, you have to make some recapture partial or not, but it's frequently to see this kind of movement of the valve. When you try to deploy more deeper, the valve tend to, at the release, tend to get down. So I think this is a very good point to point out, no?
Juan.
Yeah, no, I mean, I think you're exactly right, and I think that this is a case where if we were doing this, say, 5 or 7 years ago, where instead of a Lunderquist, you were using Safari, and instead of cusp overlap, you were implanting an LAO view or a 3-cusp view, and we just didn't have sort of the same level of meticulousness when analyzing the CT scans. I think that at that time, I think, you know, a balloon expandable probably would have been a little bit easier. But I think that you and your team, I think, expertly demonstrated how far we've come, and expertly demonstrated the versatility of this particular platform, that you could deploy it just as easily without, you know, using a lot of contrast, while still getting an excellent technical and hemodynamic result.
Okay, thank you very much for all of you. Thank you, Juan, for take.
Gracias. Thank you, Matías. Thank
for
you.
take this team in contact, and I have to say that I'm very happy of Veronica. Veronica has made a big effort to be first operator. She is a real girl in interventional cardiology. So we have to promote this, but not saying that we have women in the cath lab. We have promote that the women make the procedures. Okay, thank you.
Yeah. Thank you, Matías. Have a good day. Gracias a todos. Buen sábado.
Buen sábado.
Y que tengan un buen resto del día. Gracias a todos los del equipo por colaborar el día de hoy. Saludos.